इससे Good afternoon, everyone. Myself, Dr. Lavika Kansal, my moderator, Dr. Abhishri Ma'am. Today, I'm going to present on a topic, catatonia. Now, what is catatonia? Catatonia is a syndrome of specific motor abnormalities closely associated with disorder in mood, affect, thought, and cognition. It is basically a neuropsychiatric condition that is involving motor, affective, cognitive, and behavioral symptoms. Now, coming to the types of catatonia, it is classically of three types. First one is malignant, also known as lethal catatonia. Second one is non-malignant catatonia, called as Kolbom syndrome. And third one is delirious catatonia, also known as hyperactive catatonia. Now, coming to the malignant catatonia, it has acute onset, associated with fever, autonomic instability, leukocytosis, and increased creatine phosphokinase. It needs to be differentiated from the NMS, that is neuroleptic malignant syndrome. Now, how to differentiation between malignant catatonia and neuroleptic malignant syndrome. In neuroleptic malignant syndrome, creatine phosphokinase is markedly raised, while in catatonia, it is mildly raised. NMS arise due to presence of antipsychotic medication, while catatonia arise due to absence of antipsychotic medication or due to stoppage of medication causing relapse of symptoms. In NMS, extrapyramidal symptom is markedly raised, like muscle rigidity or tremor, while it is mild in catatonia. Autonomic symptom is present in both, like tachycardia and diaphoresis. Delirium is present in NMS, while it is absent in catatonia. Fever is present in both. In NMS, catatonic symptoms are present, like echolalia and echopraxia, while in catatonia, catatonic symptoms are present, like immobility, posturing, and poverty of speech. Now, coming to the non-malignant catatonia, also known as Kolbom syndrome, it is the most frequent form of catatonia associated, which has positive response to benzodiazepine. It has all the classical symptoms of catatonia. Now, coming to the delirious catatonia, also known as hyperactive catatonia, it shows presence of excitement, altered level of consciousness, and delirium. Patients show all the episodes of mutism, stupidness, and excitement. Now, coming to the causes of catatonia, we can see the list of causes. First one is psychiatric causes, like bipolar disorder, manic depressive psychosis, and schizophrenia. In CNS causes, we have anoxia, neoplasm, seizure disorder, or stroke. In substance abuse and medication, we have antipsychotic medication, disulfiram, and corticosteroids. Also, endocrine causes like Addison's disease, Cushing's disease, and hyperthyroidism. In India, very common in India is infectious causes like bacterial sepsis, encephalitis, malaria, neurosyphilis. Other causes like systemic lupus erythematosus, uremia, and vitamin deficiency. Very common in India is infectious causes. So we have to first rule out the infectious causes aggressively, also substance use and trauma issues. There are some neurological conditions associated with catatonia, like encephalitis, post-encephalitic states, Parkinsonism, subacute sclerosing panencephalitis, subdural hematoma, general paresis, tuberous sclerosis, and paraneoplastic encephalopathy. Also, metabolic disorders that are associated with catatonia, diabetic ketoacidosis, hyperthyroidism, hypercalcemia, pellagra, acute intermittent porphyria, Addison disease, and Cushing disease. Their investigation we have to done are full blood count, renal function test, liver function test, thyroid function test, blood glucose measurement, CPK measurement, and drug screen of urine. Now coming to the DSM-5 criteria, it has 12 points. It has 12 points, that is stupor, catalepsy, Wax's flexibility, mutism, negativism, posturing, mannerism, stereotypic, agitation, grimacing, echolalia, and echopraxia, which I will discuss later. Out of these 12 points, 3 or more should be present to diagnose as a case of catatonia. Now coming to the Bush-Francis catatonic rating scale, it is the commonest scale used to diagnose catatonia. It is used for the diagnostic purpose to know the severity of the disease and to monitor the response for treatment. It has 23 items, out of which first 14 items are screening items. Out of 14 screening items, 2 or more should be present so that we can get from 9 items and to complete the 23 items. Now starting with the first 14 items, screening items. First one is immobility or stupor, that is extreme hypoactivity or immobile. Second one is mutism. Patient is verbally unresponsive, minimally responsive. Third one is staring, that is fixed gaze or little or no visual scanning of environment. Third one is posturing or catalepsy, that is spontaneous maintenance of posture like standing or sitting for a long period of time. Fifth one is grimacing, that is maintenance of odd facial expression. Sixth one is echopraxia and echolalia. If a patient present with abnormal movements, that is echopraxia. If patient present with abnormal speech, that is echolalia. Seventh one is stereotypy, that is repetition of known goal-directed activities like patting or rubbing self. Eighth one is mannerism, that is odd purposeful movements like walking on a tiptoe. Ninth is stereotypy, that is meaningless repetition of words. 10th is rigidity, that is maintenance of rigid position. 11th is negativism, that is apparently motive-like resistance to instruction. 12th is waxing flexibility, that is repositioning of the patient. Patient offers initial resistance, like waxing of, like bending a candle. 13th is withdrawal, that is refusal to eat, drink, or eye contact. 14th is excitement, that is extreme hyperactivity. These are the 14 points which are the screening point. Out of these 14 screening point, 2 or more should be present so that we can go for next 9 items to complete it to 23 items. Now, 15th is impulsivity, that is patient suddenly engages in inappropriate behavior like taking off his clothes. 16th is automatic obedience, that is exaggerated cooperation with examiner commands. And 17th is passive obedience, that is Mittengehen. Patient raises his arm in response to light pressure to his arm. 18th is muscle resistance, that is Gagenhalten, that is involuntary resistance to passive movement. 19th is ambitendency, that is patient appear in an indecisive manner. 20th is grasp reflex, that is striking the patient hand with 2 fingers, patient closes his hand. 21st is preservation, that is patient return to the same topic repeatedly. And 22nd is combativeness, that is aggressive behavior. And 23rd is autonomic abnormality, that is abnormality of body temperature, respiratory rate, pulse, etc. Now, these are just some references. Thank you.
Good morning to you all. Today myself, Mehul Pandey. The topic for today's presentation is lamotrigine. My moderator is Dr. Arpita ma'am. Lamotrigine is a phenyltrazine class drug. It is available as a white to pale cream colored tablet in the market, and the chemical formula for lamotrigine is depicted in the picture. Now comes the mechanism of action of a drug. It inhibits the voltage sensitive sodium channel, thereby destabilizes the neuronal membrane. Along with it, it modulates the presynaptic release of excitatory amino acid like glutamate and aspartate. Now comes to the pharmacodynamic, the pharmacokinetic of the drug. Lamotrigine gets absorbed from GI tract, and after absorption, it gets transmitted to the liver for its further metabolism. It gets metabolized in the liver through the first order kinetics. There, it gets metabolized through glucouronidation, resulting in a plasma half-life of about 24 to 30 hours. After absorption, metabolism gets excreted in feces and urine majorly. Now, there are few drugs which alter the plasma concentration of lamotrigine, which are known as inducer and inhibitors. So, inducer for the drug is phenytoin, carbamazepine, and phenobarbital. These decreases the plasma concentration of lamotrigine. Therefore, we have to alter the dose so that we can have the desired result. On the other hand, drug like valproate increases the plasma concentration as it inhibits the glucuronidation. This is the picture which is depicting the plasma concentration of lamotrigine when or without giving to the inducer or inhibitor. Like on the right hand side, we can see the lamotrigine with neither valproate nor enzyme inducer. We have to give lamotrigine in a step ladder type pattern. Like in week 1, week 2, we start with 25, and one subsequent week we increases the dose with as I've shown in picture. Like week 3 and 4, we give it a 50 mg per day, 5 100, 6 200, and 7 also 200. 200 considered as a target dose according to FDA, but we can, if we want to increase the final dose, we can increase 200 to 400. Now with lamotrigine with enzyme inducer, as I've already told, the inducer decreases the concentration. Therefore, we start with higher dose and subsequently we increases. We can go maximum up to 400 to 800. And with valproate, as it increases the plasma concentration by inhibiting glucuronidation, therefore we start with low dose and we can go up to 100 to 200. Now, availability of drug is available as a tablet, chewable tablet or disintegrated tablet. It is also available as a 5-week pack, also in a convenience pack. The term convenience they associated because it is available different color coding for patient convenience. It has been seen with lamotrigine that on certain withdrawal, certain discontinuation, it leads to a withdrawal seizure. Therefore, it's been advised that to taper the drug over 2 week time. There are various brand name which is available for lamotrigine. Lamtech have various advisable drug combination with it. Like it's Tower 25, it's the smallest dose which is available, goes to 200 with the maximum. Other are Lamostan, Arigine, and Lamistal. Now the therapeutic use of lamotrigine. Lamotrigine therapeutic use has been divided according to the age of the patient. According to age, we use as an adjuvant and monotherapy. If patient is above 2 and at 2, we use the adjuvant therapy with partial seizure, GTCS, that is generalized tonic-clonic seizure, and Lennox-Gastaut syndrome. If patient is above 16 or at 16, it can be used as a monotherapy for focal or GTCS. Now, patient above 18 and at 18, we use it as the maintenance therapy for a bipolar disorder, bipolar 1 disorder, to delay the episode of mood disorder in the patient. The best thing about lamotrigine, it is the safest anti-epileptic in pregnancy, and it can be given during breastfeeding. But the thing which we have to notice during breastfeeding, that we have to regularly monitor the lamotrigine level in the child so that to avoid the adverse effect with associated with lamotrigine. Now the adverse effect, lamotrigine associated with dizziness, ataxia, blood vision, double vision, vomiting, rash, and the most important and the dangerous one is Steven-Johnson syndrome, and it is a rarest form also, but it is the most toxic and fatal in children, pediatric age group. Now the picture is depicting some of the adverse effect of lamotrigine. The right hand side you can see the normal rash we associated with lamotrigine, and the left hand side you can see the most severe and toxic form, Steven-Johnson syndrome. In this we can see the exfoliation of skin is there, blisters and papules are there over the trunk, and this is the fatal form. Now come to toxicity of lamotrigine. Lamotrigine can be fatal as when it is given as overdose as high as 16 gram due to the complications associated with a seizure, coma, and conduction abnormality. It has been said by United States box warning that lamotrigine can cause serious rash requiring hospitalization. That is, can lead to severe rash, which is fatal, as well as it can lead to Steven-Johnson syndrome. Therefore, we never advise emergency IV bolus use of lamotrigine because of these side effects. No, ma'am. The reference for my slide.
Practice not to prescribe it. Although it says कि आप गर्भोत्थान start करके slow titrate कर सकते हो, लेकिन practice में it is advisable कि अब जब तक बहुत जरूरी ना हो
Thank you, ma'am.
Good afternoon. I, Ayushi Raj, presented the topic alcoholic liver disease. Liver disease. My presenter, Dr. Anusha Agarwal ma'am. Alcohol is one of the most common cause of chronic liver disease worldwide. Hepatic manifestation of alcoholic overconsumption are fatty liver, hepatitis, alcoholic cirrhosis, Amount of alcohol present in average drink in less in beer and more in whiskey. Alcohol percentage by volume in beer is 3.5 or 9, in wine 10 or 12, alcopops in 6, sherry 17.5, and vodka 37.5, and whiskey 40. 1 unit equal to 1 unit equal to 8 gram of ethanol is present in a drink. Alcoholic liver disease doesn't occur below the threshold of alcohol consumption of less than 14 units per week in women and less than 21 units. Ma'am, 1 unit equal to 8 gram of ethanol. Ma'am, 1 unit equal to 8 gram of ethanol, and then percentage is calculated by, yes, ma'am. Average threshold of alcohol is in women is less than 14 units per week, and in men less than 21 units per week. Risk threshold for developing ALD is variable but begins at 30 gram per day of ethanol. Average alcohol consumption of a man with cirrhosis is 160 gram per day for over 8 years. Risk factors for ALD is drinking pattern. Liver damage is more likely to occur in continuous rather than intermittent drinkers. Gender, female is more susceptible than the males. Genetic alcoholism is more concurrent in monozygotic than the dizygotic twins. Nutrition, obesity increases incidence of liver-related mortality and hepatitis C infection. Pathogenesis, 80% of alcohol is converted by the alcohol dehydrogenase into acetaldehyde, and then acetate plus acetyl coenzyme by the aldehyde dehydrogenase. In liver, acetaldehyde form adducts which affect immune system and that causes liver injury. 20% of alcohol metabolized by the cytochrome P2E1, which increases free radicals in liver that led to lipid peroxidation and low glutathione. It also increases gut permeability, which increases endotoxin and that affects liver cells, Guffer cells, that led to tumor necrosis factor alpha increase and interleukin 6 and 2 that led to inflammation of the alcohol. Pathological changes in fatty liver, there is increase in triglyceride levels. If there is an exposure of alcohol, normal liver exposes to alcohol, it led to fatty liver. If there is an absence of alcohol, it gets to normal. It gets to normal liver in 3 weeks. If there is a no exposure, if there is an exposure of alcohol, it led to hepatitis, and the repeated exposure led to cirrhosis. There is a fibrosis of the liver cells. Alcoholic hepatitis. And repeated exposure of alcohol led to fibrosis, which led to cirrhosis of liver. Clinical syndromes of alcoholic liver disease. In fatty liver, it may be asymptomatic or abnormal liver biochemistry, normal or large liver, right upper quadrant discomfort, nausea, rarely jaundice is present. In alcoholic hepatitis, asymptomatic, jaundice, malnutrition, hepatomegaly is seen, features of portal hypertension, ascites, encephalopathy. In cirrhosis, stigmata of chronic liver disease, ascites, varices, encephalopathy, large or normal or small liver, and hepatocellular carcinoma may be seen in cirrhosis. Stigmata of ALD, it will to clubbing, gynecomastia, jaundice, palmar arrhythmia, spider nevi, caput medusa, or diptera contracture. Investigation aspartate transaminase increases to 2 to 7 folds. Alanine transaminase increased 2 to 7 folds, less than 200 unit per liter. AST to ALT ratio is usually more than 1. GTP not specific to alcohol, easily reducible, but elevated in all forms of fatty liver. Bilirubin may be markedly increased in alcoholic hepatitis. Prothrombin time may be increased, prolonged. Albumin hypoalbuminemia. PMN is more than 5,500 per ml, predicts severe alcoholic hepatitis. Polymorphonuclear. Neutrophils. In alcoholic hepatitis, treatment is alcohol absentee or nutritional support. If discriminant fraction is more than 32 or MLD is more than 21, ma'am, in this prothrombin time and bilirubin fraction is seen. If it's more than 32, then it is prescribed that preferred is corticosteroid treatment will be given, prednisolone, 32 mg. But ma'am, this is also criteria for treatment. MLD and Glasgow scale is criteria for treatment. Modified. Treatment option preferred is prednisolone 32 mg per oral daily for 4 weeks and then taper down for 4 weeks. And alternate is pentoxifylline 400 mg per oral thrice a week for 4 weeks, thrice a day for 4 weeks.
Inflammation complete.
My references is Harrison and Davidson. Thank you.
Good afternoon, everyone. I, Ashish Gaurav, am presenting a case of PowerPoint presentation of intravenous fluid. Now we need to lay down some basic ground rules in this picture. Intake and outtake. The plasma here mentioning is the blood vessel composition. Now colloids cannot transport from blood vessels to interstitial fluid or cell membrane, but the crystalloids that contains iron can freely transport as according to the deficit created in the body. Now, what are the goals of fluid therapy? We have to maintain normovolemia, hemodynamic stability. We have to have acceptable plasma colloid or oncotic pressure. We have to correct electrolyte imbalance. We have to correct acid-base imbalance. And we have to have adequate urine output of 0.5 to 1 ml per kg per hour. Now, what are the types of fluid? Maintenance fluid, which replaces insensible fluid loss, such as dextrose, 5% dextrose, and dextrose 8.45% NS, which is useful in DKA, diabetic ketoacidosis treatment. Then replacement fluid, where there is any form of fluid loss from gastric drainage, vomiting, diarrhea, infection, trauma, burns. Then there are special fluids which are for specialized purposes, such as 25% dextrose for hypoglycemia, hypokalemia requires injection KCl, and metabolic acidosis requires injection soda bicarbonate. Then the types of fluid, crystalloids, colloids, and blood products. Here we will discuss crystalloids and colloids. Colloids are large molecules that don't pass the cell membrane. They remain in blood vessels. From there, they change the fluid composition of the extravascular space, that is tissue, and intracellular space, and blood vessels. Crystalloid. Crystalloids are membrane that contain ions which flow easily from bloodstream into the cells and body tissue. They increase both interstitial and intravascular fluid composition. They can change. They are divided into isotonic, hypotonic, and hypertonic. Now here is a picture depicting isotonic concentration. Isotonic is a state of equilibrium. Here the transport of fluid does not stop, but it occurs in equilibrium manner in both directions. And then hypotonic. Hypotonic solution contains more fluid in blood vessels. So fluid flows from interstitium to the intracellular. Then there is hypertonic, which contains more osmolality, so the fluid can flow back to the blood vessel. Now, isotonic solution. It includes sodium chloride, lactated Ringer's solution, 5% dextrose, and Ringer's solution. Ringer's solution is different from lactated Ringer's solution because in Ringer's solution, instead of sodium lactate, there is sodium bicarbonate present. Now, normal saline. It contains sodium 154 milliequivalent and chloride 154 milliequivalent. Now, the chloride composition is important because it is slightly higher than our normal body chloride ion composition, that is about 96 to 104 milliequivalent, which is normal. Here it is higher. Now, it provides my pharmacological basis. It provides major extracellular electrolytes. It corrects both water and electrolyte deficit, and it increases IV volume substantially. Now, where should we avoid it? We should avoid it in preeclamptic patient, CHF and renal disease and cirrhosis, because here the body can go into hypervolemic state, and dehydration with severe hypokalemia because there is no potassium concentration. So it will cause more hypokalemia. Now, large volume may lead to hyperchloremic acidosis. I said the volume of chlorine is higher, slightly higher. Therefore, it can cause hyperchloremic acidosis. Now, indications. It is useful in diarrhea and vomiting, hypovolemic shock, alkalosis with dehydration, hyponatremia, IV fluid therapy in diabetic ketoacidosis, hypercalcemia. It can be used in irrigation, washing body fluids, and it can be used for vehicle for certain drugs. And it can also be used in fluid channel challenge in pre-renal acute renal failure. Now, what we should be cautious in giving normal saline in case of cardiac or renal disease patient, because it can be it can cause fluid overload. Now, Ringer's lactate. Ringer's lactate contains sodium, potassium, chloride, lactate, and calcium ion. Now, some places instead of lactate ion, acetate is also preferred. Acetate is preferred because lactate when it goes into liver, it causes lactic acid production, which can cause metabolic acidosis prolonged. But acetate contains malate ions. It causes provides a buffer to the acidity already present. Therefore, sometimes acetate is also used. It is the most physiological fluid. It rapidly expands IV volume. Therefore, it is preferred in burns patient. Now, indication. We have to give it in severe hypovolemia, burns, diarrhea, including hypokalemic because it contains potassium. It is a choice in diarrhea-induced dehydration. It is useful in diabetic ketoacidosis. It is useful in maintaining normal extracellular fluid and electrolyte imbalance. Contraindication, liver disease because it contains lactate ion, which could produce lactic acid in liver. But in liver disease, there is a problem in liver. In severe CHF, lactic acidosis can take place. Addison's disease, vomiting or nasogastric tube induced alkalosis. And it is contraindicated in simultaneous infusion of Ringer lactate and blood because Ringer lactate in blood can cause hemolysis and clumping. Sodium, now point to be noted. Sodium chloride and Ringer lactate may be used in clinical situations. but patient in many clinical situations, such as surgical or burns patient, but they will be more beneficial from ringer lactate because it is more physiologically suitable for us. Now 5% dextrose. 5% dextrose contains glucose. It corrects dehydration and supplies energy. It is useful in prevention and treatment of dehydration, pre-op and post-op fluid treatment, fluid replacement, IV administration of various drugs, in prevention of ketosis, so that it can provide extra glucose. Therefore, ketosis pathway is not followed by the body. In starvation, vomiting, diarrhea, it can be given adequate glucose infusion protects liver from toxic effects. And it can also be used in the correction of hypernatremia. Contraindication, cerebral edema. In cerebral edema, it should never be given because in case of cerebral edema, initial sometime very low, body has very little time to give this solution. But at that time, the patient never comes. By the time the patient comes to us, body itself has gone into some form of compensatory phase. And when we give these type of fluid, it can cause more harm to the patient. It is never recommended in acute ischemic stroke, hypovolemic shock, hyponatremia, water intoxication. Same IV line blood transfusion, hemolysis and clumping can occur in uncontrolled diabetes mellitus and severe hyperglycemia. It should never be given in patient with renal failure, cardiac or cardiac problems. It can cause fluid overload. In case of intracranial pressure, it should not be given as it can cause cerebral edemas. It should not be mixed with blood. It causes hemolysis. And it should not be used for resuscitation because the fluid will never remain in intravascular space. It can lead to vascular collapse. It is not used in early post-operative period because the body is in stress. So there is increase in extra antidiuretic hormone, thereby leading to increase in blood volume and leading to hypervolemia. Precautions. We should never, hypovolemia patient can quickly develop hypervolemia. Therefore, we should prevent overinfusion of these fluids. We should always take vital signs. We should always check for edema, ankle edema, lung sounds for crepitations, heart sounds before beginning the infusion. Now, what are the signs? We should always monitor, we should always check for hypertension, for hypervolemia, hypertension, bonding pulse, pulmonary crackles, peripheral edema, dyspnea, shortness of breath, or jugular venous distension. We should always monitor intake and output. We should always elevate head to 35 to 45 degree because jugular venous distension can occur. If edema is present, we should always elevate the legs of patient so that venous outflow can occur properly. What are the signs of hypovolemia? Hypovolemia, the urine output is less than 0.5 ml per kg per hour. Patient has poor skin turgor, tachycardia, weak and thready pulse, hypotension. We should always educate patient and families about symptoms of both volume overload and dehydration. We should instruct patient to notify if they have trouble breathing or notice any swelling. Instruct patients and families to keep the head elevated unless contraindicated. Hypotonic fluids. Hypotonic fluids are those fluids which have osmolarity less than 250 milliosmol per liter. They cause hypotonic, therefore fluid is more. They cause fluid shift from blood vessels to the interstitial fluid and cells. Types of hypotonic fluids. They contain 0.45% sodium chloride and sodium chloride in other concentration along with 0.25% dextrose in. They are used to treat patients with conditions causing intracellular dehydration, such as hypernatremia, diabetic ketoacidosis, and HSS, that is hyperosmolar hyperglycemic state. Hypotonic fluids. Precaution. We should never give it in patient of increased intracranial pressure because it can cause cerebral edema, because the compensation has already occurred in the body. We should not use hypotonic with liver disease, trauma, or burns due to their potential for depleting the volume of intravascular fluid. Precautions. It can worsen in case of hypovolemia and hypertension. Hypotonic fluid. We should monitor signs and symptoms of fluid volume deficit. In older patients, confusion may be an indicator of fluid volume deficit, and if patient feels dizzy, we must be careful with them in hypotonic solution. Now, hypertonic solution. They have an osmolarity of 375 milliosmol per liter or higher. They are usually used for drawing the fluid outside into the blood vessels. They are volume expanders. Some examples are 3% sodium chloride, which is used for treatment of severe hyponatremia. And in patients of cerebral edema, it is preferred. Dextrose with normal saline, D5NS. It replaces sodium and chloride and some calories. Now DNS, that is D5NS, it contains sodium chloride and glucose. It supplies major electrolytes as well as energy to the body during dehydration. It is used in condition with hyponatremia and hypovolemia and correction of volume or nasogastric tube in aspiration induced alkalosis and hypochloremia. Contraindication, it is not preferred in anasarca because anasarca, the fluid is usually much more present in interstitial space. In cardiac, hepatic or renal disorder or in hypovolemic shock. Precautions with hypertonic fluid. It should not be, it has the potential for causing intravascular fluid volume overload and pulmonary edema. Since the heart will have more pressure due to fluid overdose, therefore it can cause pulmonary edema. Now, prescription for using of hypertonic fluid should be specific, total volume, how much to be infused, and what is the infusion rate or the length of time till the infusion is to be continued. This must be very specific. Now, isolate fluids. Now, here in this table, isolate fluids, we have to notice some change, some parts such as acetate content, which is higher in isolate E, as well as magnesium content is present in isolate E. Ammonium chloride is present in only isolate G. And these, no, and these are replenishing fluids. मैम ये बहुत कम प्रेफर मतलब नॉर्मली ये ज्यादा जल्दी नॉर्मल सैलाइन वगैरह अवेलेबल होते हैं ना, वैसे इनका पीडियाट्रिक जैसे आइसोलेट फ्लूइड आइसोलेट पी, इट इज यूज्ड एज अ मेंटेनेंस फ्लूइड इन चिल्ड्रन. They require less, as they require less electrolytes and more water. Contraindication in hyponatremia and renal failure. Now isolate E, I said isolate E contains more potassium as well as acetate. Therefore, it is useful in and also contains is the only IV fluid which corrects magnesium deficiency. Therefore, it is used in magnesium deficient. It is usually preferred in children. It is useful in treatment of diarrhea, metabolic acidosis, and it is not used in metabolic alkalosis. Here I told you about acetate. Acetate contains malathion. Therefore, it is not preferable in metabolic alkalosis. Now, isolate G. Isolate G, I said it contains ammonium ions, ammonium chloride. Here, ammonium chloride, ammonia gets converted into H plus in liver. Therefore, it can be used for treatment of metabolic alkalosis. And isolate M. Isolate M is the richest source of potassium. Therefore, it can be used for hypokalemia. Colloid solution. Now, I told earlier that colloid solution, that is albumin, never leaves the intravascular space. So any fluid maintenance will always be the fluid will move, but never albumin, and thus the fluid shift will be maintained. Now it acts just like hypertonic solution. So it causes the high oncotic pressure, and here is a comparison. 1 ml blood loss is equal to 1 ml of colloid can be given, and 3 ml of crystalloids. I said colloid and crystalloid hypertonic solution are same. Now, the same effect as hypertonic crystalloids, less volume and have a longer duration of action because the molecules remain in intravascular volume for long. The effects can last for several days if capillary linings are intact and working properly. Albumin. Albumin maintains plasma oncotic pressure approximately 80%. It maintains. There are different forms of albumin present, that is 5%, 20%, and 25% commercially available. Now here are some pressure value they give. 5% albumin gives colloidal osmotic pressure of 25 millimeter of mercury, and 25% albumin gives about 75 millimeter of mercury. It expands up to 4 to 5 times the volume infused. Now in adults, we can give a rate of infusion. We can give initially 25 grams, and then for 5% albumin, we should give 1 to 2 ml per minute, and for 25%, we can give 1 ml per minute. Indications. In case of hypovolemic shock, burns, and severe hypoalbuminemia. Because in burns, there is loss of proteins, therefore it is preferred there. In hypoproteinemia, it is preferred. And in diuretic resistant nephrotic syndrome. In contraindications, in severe anemia, cardiac failure, And since it is a protein, therefore there is a chance of hypersensitive reaction. Colloid. Dextran. Now, use of dextran is normally where blood circulation is involved because it is safe in vascular compromised status. So it is effectively expands IV volume, and it is anti-thrombotic, inhibits platelet aggregation, and it improves microcirculatory flow. Therefore, it is preferred in vascular compromised states. Indication: hypovolemia correction and prophylaxis of deep vein thrombosis and post-operative thromboembolism. It improves blood flow and microcirculation in threatened vascular gangrene. Here all are vascular conditions where it is preferred. Myocardial ischemia, cerebral ischemia, peripheral vascular disease, and maintaining vascular graft patency. Adverse effect: it can cause acute renal failure. It can interfere with blood grouping and cross-matching, and it can cause hypersensitive reaction as it is a protein. Precautions: we should not give in severe oligouria, CHF, circulatory overdose, and in bleeding disorders like thrombocytopenia because it inhibits platelet aggregation. Therefore, we should never give it in thrombocytopenia where platelet itself is less. Then it can cause severe dehydration. Anticoagulant effect of heparin is enhanced because it inhibits platelet aggregation. Hypersensitive, it should not be given in hypersensitivity to dextran. We should administration, we can give in adult about rapid 500 ml IV infusion, and in first 24 hours, it should never exceed dose of 20 ml per kg. And in next 5 days, it should it should be about 10 ml per kg per day. Now, precautions when using colloid solution. Patient is at risk of fluid overload. As for blood product, we can use 18 gauge needle and a larger needle to infuse colloid. We should monitor the patient for signs of hypervolemia, such as increased BP, dyspnea, and crackles in lungs, edema. We should closely monitor intake and output. Same precautions are to be taken in crystalloid and colloid. And anaphylactoid reactions, because it is a protein, they are rare but potential lethal reactions to colloid. Therefore, we should always take careful allergy history from patient receiving colloids, asking specifically if they have had a drug reaction to IV infusion. Now, how to calculate maintenance fluid rate? There is a common 4-to-1 rule, which is used in both adult and pediatrics. Here, 4 ml per kg per hour for first 10 kg we can give, which equals to 40 ml per hour. For the next 10 kg, we can give 2 ml per kg per hour, which is equal to 20 ml per hour. And then rest, we can give 1 ml per kg per hour. So the shortcut is that for 20 kgs, we can give approximately 60 ml per hour. And after that, for each kg weight increment, we can increase 1 like that. So the short formula is weight in kg plus 60 is equal to maintenance IV rate per hour for any person weighing over 20 kg. Now, this is Holiday-Segal method, which is for pediatrics preferred. For 0 to 10 kg, we require 100 ml fluid, that is in 24 hours per hour 4 ml. And for 11 to 20 kg, 50 ml plus 100 ml, and then for 24 hours 2 ml per hour. And for more than 20 kg, we require additional 20 ml and per hour 1 ml. Now, fluid resuscitation. Fluid resuscitation is when to use in case of hypovolemic shock. What are parameters to assess in volume deficit? Blood pressure, urine output, JVP, and urine sodium concentration. How to know that the patient is in hypovolemic shock? He has anxiety, agitation, cool, pale skin, confusion, decreased or no urine output, rapid breathing, disturbed consciousness, low blood pressure, low body temperature. Now, what should we do? Rapid pulse and often weak and thready. Here picture, what should we do? We should place the victim in in lying down position. We should keep a warm and comfortable blanket on the person, and we should turn the patient to side if the neck injury is not present. Rate of repletion of fluid deficit. We can give rapidly infuse 1 to 2 liter of 0.9% normal saline in severe hypovolemic shock. In mild to moderate, we can choose a rate that is 50 to 100 ml per hour greater than estimated fluid loss. Estimated fluid loss via urine 50 ml per hour is present, and insensible losses 30 ml per hour is present. Additional losses can be 150 ml per day for vomiting, diarrhea, or high fever. Now, fluid hypovolemia. It can be due to excess parenteral infusion, deficiency, or cardiovascular renal fluid volume problems. Signs and symptoms, they are not very typical, but it can be edema, particularly in feet and ankle. It can be difficulty, dyspnea, difficulty breathing lying down, crackles on auscultation, and there can be high blood pressure, irritated cough, and JVP distension, and there is shortness of breath. Strong and rapid pulse. Management of hypovolemia. Prevention is the best way. Sodium restriction should be given. Fluid restriction should be done. Diuretics should be given. And dialysis is preferred. Now, IV flow rates. IV flow rate, what is drop factor? Drop factor, number of drops per minute that is to be given. Now, these are some standardized drop factors. For blood set, 10 ml, 10 drops per ml. For regular set, 15 drops per ml. And for micro drop burette, 60 drops per ml. Now, here are some pictures of IV administration set. Now, how to calculate IV flow rate? Now, suppose from an example, there is a 1500 ml IV saline order for 12 hours. Now, we had learned that for regular drop rate is of 15 drops per ml. So, using a drop factor of 15 drops per ml, how many drops per minute is needed to be delivered? So, the volume of IV saline 1500 ml into the standardized drop factor 15 drops per ml upon time in minutes, that is for 12 hours, 12 into 60, it gives 31 drops per minute. That can be catered for individual needs. References.